7 millimeter suspicious thyroid nodule close to the carotid artery. Local anesthesia is given along the tract and on the thyroid capsule. Hydrodissection is an important step which helps to create space between the thyroid nodule and the critical structures like the carotid artery, esophagus, recurrent laryngeal nerve, and the trachea. Here we are inserting a fine needle. Initially, the needle has to be as close to the carotid artery as possible. After we inject the saline, the space opens up, and then to separate the nodule from the esophagus, we stay as close to the thyroid gland as possible. And we continue our dissection to push the esophagus posteriorly. We are inserting the microwave probe into the thyroid nodule under vision. We check the position of the hydrodissection needle and inject some saline to create the space between the nodule and the esophagus. And as I am ablating the nodule, my assistant injects saline to prevent lateral thermal injury. During this procedure, it is absolutely essential to visualize the entire probe. When we insert the probe in the posteriormost aspect of the nodule, to avoid injury to the esophagus, we lift the nodule anteriorly, and as we buzz, we make sure that there is continuous injection of the normal saline. We check for the vascularity, and any residual lesion is precisely ablated. As we are ablating, it's important to see both the needles, the microwave probe and the hydrodissection needle, to prevent lateral thermal injury. At the end of the procedure, we confirm that the nodule is fully ablated and has no vascularity.